Good morning. I am Dr. Monica Rathor, Professor and Head, Department of Pediatric and Preventive Dentistry, BBDCODS, BBD University. Today I will be discussing about avulsion. I will be covering the topic under following headings: Introduction, Management at the Accident Site, Management of avulsed permanent anterior tooth with closed apex, Role of antibiotics in avulsion, Follow-up schedule. So tooth avulsion implies the complete displacement of a tooth from its socket due to trauma. Prompt and correct emergency management is essential for attaining best outcome after this injury. The management at the accident site. So immediate reimplantation is the best treatment at the site of accident. The dentist should always be prepared to give appropriate advice to the public about the first aid for avulsed teeth. So what are the steps for reimplantation? Ask the patient to remain calm. Ask the patient to make sure that it is a permanent tooth because primary teeth are never reimplanted. Ask the guardian or parents to find the tooth and pick it up by the crown part. Avoid touching the root part because it will cause damage to the PDL cells. If the tooth is dirty, rinse it gently in milk, saline or patient saliva, whatever is available at the accident site. Try to encourage the patient guardian to reimplant the tooth at the emergency site. Once the tooth is placed in the socket, ask the patient to bite on handkerchief so that it will hold the tooth in the position. If the reimplantation of the avulsed tooth is not possible, maybe the patient is unconscious or the parents are unable to place the tooth in the socket, the tooth has to be placed in the storage media or transport media, whatever is available at the accident site. This will help in dehydration of the root surface and the viability of the PDL cells will be more. The tooth can be transported in patient's mouth. We can ask the patient to keep the tooth inside the lip or cheek if the patient is conscious. If the patient is too young, he or she may swallow the tooth. In that condition, we may ask the patient to spit in a container and the tooth can be placed in the container. Ask the parents to seek emergency dental treatment immediately. Once that patient reaches the dental clinic, a brief case history is recorded: when, where and how the trauma occurred, how much time was lapsed, whether the tooth was stored in a storage media, what was the extraoral dry time, what type of storage media was used, and then the examination of the avulsed tooth is done and alveolus is also examined to find out if any fracture is there, and extraoral and intraoral examination is done to find out other types of injuries and whether the patient became unconscious or whether there was any history of trauma. All these things are recorded. Now, what are the treatment guidelines for avulsed permanent anterior tooth? The treatment depends on two factors. First is the maturity of the root, whether the apex is open or apex is closed, and condition of the periodontal ligament cells. The condition of the cells depends upon the storage media, and the extraoral dry time is critical for the survival of the PDL cells. It has been found that after a dry time of 60 minutes or more, the PDL cells viability is compromised. Most of the cells become non-viable after 60 minutes of extraoral dry time. So, before starting the treatment, clinician roughly can classify the avulsed tooth in one of the three groups. The first group is that the tooth was reimplanted immediately at the accident site or within 15 minutes. The second group is The tooth was reimplanted within 60 minutes. So the extraoral dry time was less than 60 minutes. The third group is the tooth was reimplanted after 60 minutes. So the extraoral dry time was greater than 60 minutes. In the first group, when the reimplantation was done immediately, mostly all the PDL cells will be viable. When the extra in the second group, when the extraoral dry time is less than 60 minutes, the PDL cells may be viable, but they are compromised. In the third group, when the extraoral dry time is greater than 60 minutes, that means the tooth was reimplanted after 60 minutes, PDL cells may are becomes non-viable. So now briefly we will discuss all the three categories. The first group is when the tooth was reimplanted at the accident site before the patient's arrival at the clinic. First, you should evaluate the reimplanted tooth, clean the area with water spray, saline or chlorhexidine, suture gingival lacerations if present, verify the position of reimplanted tooth both clinically and radiographically, apply flexible splint for 2 weeks, administer systemic antibiotics, check for tetanus protection, give patient instruction, and root canal treatment should be initiated 7 to 10 days after reimplantation. The second category is when the reimplantation was done within 60 minutes. So the extraoral dry time is less than 60 minutes. The first step is you should clean the root surface with a stream of saline and soak the tooth in saline. Administer local anesthesia. Gently irrigate the socket with saline. Examine the alveolar socket. If there is any fracture of the socket wall, reposition it with an instrument. Now reimplant the tooth slowly with slight digital pressure. Suture gingival lacerations if present. Verify the position of reimplanted tooth both clinically and radiographically. Apply flexible splint for 2 weeks. Administer systemic antibiotics. Check, check for tetanus protection. Give patient instruction. And initiate root canal treatment within 2 weeks after reimplantation. The third category was when the extra oral dry time was longer than 60 minutes. Means that the tooth was reimplanted after 60 minutes. This is also known as delayed reimplantation and it has a poor prognosis. The reason is because the periodontal cells become necrotic and we cannot expect them to heal. But we still go for delayed reimplantation because for aesthetic, functional and psychological reasons. The technique for delayed reimplantation is first you should remove the attached non-viable tissues from the root surface and as done, the root canal treatment should be initiated immediately before we can carry out the root canal treatment before the reimplantation or 7 to 10 days later like in other reimplantation situation. Now, first give local anesthesia, irrigate irrigate the socket with saline, examine the alveolar socket. If there is fracture of the socket wall, reposition it with suitable instrument. Now reimplant the tooth. As this is a delayed reimplantation, chances of osseous replacement is greater. So to slow down that process, the root surface is treated with 2% sodium fluoride solution for 20 minutes prior to reimplantation. Next, we suture the gingival lacerations if any present. Verify the position of reimplanted tooth clinically and radiographically. Apply sterilize a tooth for 4 weeks. Administer systemic antibiotics, check for tetanus protection and give patient instruction. After doing the reimplantation, the patient instruction remains same in all the three groups, whether the tooth was reimplanted immediately or whether the tooth was reimplanted within 60 minutes or longer delayed reimplantation. The patient instructions are the patient should avoid contact sports, he should maintain soft diet for 2 weeks, brush they should brush their teeth with soft toothbrush after each meal. Administer chlorhexidine mouthwash twice a day for 1 week, and the concentration is 0.12% chlorhexidine should be advised. Now, what is the role of antibiotics in avulsion? Antibiotics are recommended to prevent infection-related reactions and to decrease the occurrence of inflammatory root resorption. Sometimes antibiotics are given because of patient medical condition or concomitant injuries. In that, antibiotic coverage is necessary. The amoxicillin or penicillin remains the first choice because of their effectiveness on oral flora and low incidence of side effects. After the reimplantation is done, the patient is monitored clinically and radiographically, and the recall is kept for the patient is asked to come for 2 weeks, 4 weeks, 6 months, and 3 weeks, 3 months, 6 months, and 1 year. And clinical and radiographic examination are done at every visit. To evaluate, we can get two types of outcome, favorable outcome and non-favorable outcome. The favorable outcome may be the favorable outcome are the tooth should be asymptomatic in the follow-up visit. There should be normal mobility, normal percussion sound. There should not be radiographic evidence of any resorption. The laminar dura should appear normal. And in the follow-up, the unfavorable, if you notice any of these symptoms, with that suggests the unfavorable outcome. The tooth may be symptomatic, there may be presence of excessive mobility or no mobility suggesting of ankylosis with high pitch percussion sound, or radiographic evidence of resorption, may be inflammatory infection related resorption or ankylosis replaced resorption. All these suggest unfavorable outcome, means that your treatment was not successful. So this was about the management of avulsed permanent anterior teeth with closed apex. I hope this lecture was useful. Thank you.